Hello, I'm Dr. John Iskander. Welcome to CDC Beyond the Data. I'm here today with Dr. Katherine Fleming-Dutra, Deputy Director of CDC's Office of Antibiotic Stewardship. So, Katherine, we heard at today's public health grand rounds about some of the issues around antibiotic use and antibiotic resistance. Let's start with a working definition of what antibiotic stewardship is.
So antibiotic stewardship is the effort to measure and then improve antibiotic use so that antibiotics are only used when needed, and when needed they're used correctly, meaning the right drug at the right dose for the right duration.
So that's a great start. I think a lot of our audience certainly has heard and has been hearing for a while about issues around antibiotic resistance. What is the main driver of that, and how big has the problem become?
So antibiotic use is a major driver of antibiotic resistance, and it's the major modifiable driver of antibiotic resistance as well. Antibiotic resistance is a very important public health problem. CDC estimates that 2 million illnesses and 23,000 deaths a year are caused in the United States by antibiotic-resistant infections. And it's really important to remember that antibiotics are really important to modern medicine. They allow us to do surgeries, treat cancer, to prevent and treat bacterial infections in many of our vulnerable patients. So having effective antibiotics is really important for modern medicine as well.
And another thing that was featured in the session was that it's not only that inappropriate antibiotic use drives antibiotic-resistant bacteria, there are other harms as well. What are some of those?
That's a great question. So we talk a lot about antibiotic resistance, but many patients don't really realize that there are other harms. So as with any medication, antibiotics also have side effects and adverse events that can be caused by antibiotics. One of the most important ones, or one of the ones that CDC works quite a lot on preventing, is something called Clostridium difficile infection, or C. difficile infection. It's caused by antibiotic use. C. difficile is actually a bacteria that can overgrow when someone uses antibiotics and cause a very serious infection. And additionally, antibiotic resistance, as we talked about, it's an issue both at the population level and for that individual who takes antibiotics. They can be at risk in the future for antibiotic-resistant infections as well.
So one of the most striking numbers that I'll retain from this session is the proportion of antibiotic use that we scientifically study to be inappropriate. What is that, and can you give us a little context on that number?
Right, so CDC estimates that at least 30% of antibiotics prescribed in the outpatient setting in the United States, particularly in doctors' offices and emergency departments, are unnecessary, meaning that no antibiotic was needed at all. And so, for example, many antibiotics are prescribed for things like common colds, which are caused by viruses, for which antibiotics don't help the patient, but yet can put the patient at risk for these adverse events and harms, including C. difficile infection and antibiotic-resistant infections. We estimated that number comparing the antibiotics that are prescribed for the diagnosis for which they're prescribed, and comparing those to national clinical practice recommendations from health professional societies about when antibiotics are needed for particular infections. So yeah, I think a lot of our audience probably this is not news to them that antibiotics are not indicated for uncomplicated colds. But there are a number of other diagnoses, common diagnoses, for which antibiotics may either almost never be indicated, or that there may be alternatives to antibiotics. What are some of those other common conditions? It's a great question. So, for example, I'm a pediatrician, and so one of the common infections that pediatricians see is acute otitis media, or middle ear infections. Antibiotics are sometimes needed to treat middle ear infections, but they're also the clinical practice guidelines also recommend a strategy called watchful waiting, in which you wait a few days for mild ear infections to see if the child gets better before deciding whether or not they need antibiotics. Additionally, in adults, sinusitis is a very common infection, or sinus infections, but that's another another infection in which professional guide or national clinical practice guidelines from professional societies, some of them recommend watchful waiting before deciding whether antibiotics are needed, because many patients will get better without antibiotics.
So you mentioned being a pediatrician. That's a background we both share. And one of the interesting aspects of the data presented in this session was that in pediatrics, we actually have made a little progress in how we use antibiotics. Tell us a little about that, and what are the lessons for our colleagues who provide primary care for adults?
So, thank you. So we have seen in the last several years, from 2011 to 2015, that overall outpatient antibiotic use among children in the United States has been decreasing. And there's probably many reasons for that. One very important lesson that we can learn from that progress is that vaccines are a good antibiotic stewardship tool. So for example, the pneumococcal conjugate vaccine, which was introduced in the US for children in 2000, the 7-valent, and then it was an expanded valent introduced in 2010. That vaccine has been very effective, has reduced pneumococcal infections, and one of the most common pneumococcal infections is acute otitis media or middle ear infections. So reducing disease has led to less need for antibiotics to be used in the population. And additionally, pneumococcal conjugate vaccine has also directly targeted resistant pneumococcal infections. And so that has also allowed us to move to using more narrow spectrum antibiotics for these common infections. So getting at the improving antibiotic selection and not having to use our broader spectrum antibiotics as well. Another lesson learned is that there has been a lot of collaboration between professional societies from pediatricians and pediatric infectious diseases doctors, for example, and CDC and public health to work on improving antibiotic prescribing to children. And CDC has actually had efforts to improve antibiotic prescribing among children for many years, since the mid-1990s.
Yes, I certainly, in my early days in public health, was involved with some of those efforts at a state level. So certainly we can then use some of those same vaccines more and better in adults, and we can work with professional societies that are involved in adult medicine. So we heard from Dr. Jeff Linder today about some different types of approaches to changing prescribing behavior. A lot of which draw on insights from behavioral economics. What are some of those interventions, and how do those work?
Yes. So one of the things that we have learned over many years is that while education about appropriate antibiotic use is of course important, patients and physicians and clinicians need to know when to use antibiotics appropriately. It's not enough to change behavior in antibiotic prescribing practices. So some of the interventions that were talked about today help nudge clinicians or move clinicians in the right direction to help make the right antibiotic prescribing decision easier or for them to do. So for example, they talked about a commitment poster in which the clinician has basically written a letter to their patients committing to use antibiotics appropriately only when they provide more benefit to the patient than cause harm. And that poster is then displayed in the examination room so that the clinician sees a reminder of their commitment to their patient at the time of the exam. And that has been shown to improve antibiotic prescribing, reduce antibiotic prescribing for conditions for which they're not needed. And that's really a nudge. So the clinician still has the freedom to prescribe antibiotics when they need to, but it reminds them to do it in a way that's concordant with guidelines. Another intervention that we talked about today was peer comparisons. So where the physician or clinician gets an email that tells them how they're performing compared to their top performing peers who are prescribing antibiotics in concordance with guidelines for certain conditions. And that's also been shown to be effective.
Yeah, I remember asking Dr. Linder about how do clinicians react when they see something that says, you are not a top performer? Don't they get upset? And his answer was, that's part of how it works, by engaging emotions, because again, as you said, simply providing the facts by itself hasn't really moved the needle in appropriate prescribing very much. So let's come back to the bigger picture doctors and other prescribers are working in clinics, in hospitals, in these larger institutions. What are some of the policy innovations or levers that can be used to, on a population level, help better use antibiotics?
So CDC has actually put together a series of core elements of antibiotic stewardship across the spectrum of healthcare. We have one for hospitals, for nursing homes, as well as for the outpatient setting. And while those documents are from CDC, so they're really a framework. They provide a framework of how antibiotic stewardship can be implemented within these healthcare settings. And then other partners, such as the Center for Medicare and Medicaid Services, or CMS, have then taken the core elements from CDC and are using or recommending those, or sometimes even requiring those as part of increase implementation and uptake of the core elements. Another example is the Joint Commission, which is an accrediting organization for healthcare facilities, has having an antibiotic stewardship program, at least for hospitals, in their accreditation standards, and that has also increased the uptake of the core elements of antibiotic stewardship.
So you have a very interesting array of interventions at the policy, at the practice, and at the individual provider level. Are there upcoming events or observances, or are there things about campaigns to promote appropriate antibiotic use that you'd like our audience to know about?
Yes. So CDC has an educational effort now called the Be Antibiotics Aware Smart Use Best Care educational effort. And it's the mission of that effort is to educate both the general public and healthcare professionals about appropriate antibiotic use in effort to combat antibiotic resistance and to improve patient safety. And we have we have lots of tools and resources available on our website for Be Antibiotics Aware that clinicians and patients can use. Additionally, CDC has a national, the U.S. Antibiotic Awareness Week observance that happens every year in November. This year it'll be November 12th through the 18th. And that actually it coincides with World Antibiotics Awareness Week and observances in multiple other countries around the world. And that's a time in which we really try to raise awareness about appropriate antibiotic use, combating antibiotic resistance as well.
So I think that's a good note to end on, reminding ourselves that appropriate antibiotic use is part of both healthcare quality and protecting patient safety. Thank you very much, Dr. Fleming-Dutra.
Thank you.
Please join us next month for CDC Beyond the Data.